Yes.
My presentation. Good, good. So, yeah, thank you all because, yeah, we do love seeing the effort that you put in. And this is a real value for you all because we're turning this back into presentations for you, just beautiful illustrative work that you do, and then we can repackage and represent. And so, very much appreciated. It was, again, of course, a hard decision. I got some lovely cases. But let's go with this one. I had to just flip a coin because there was two or three that were awesome. 36-year-old male, recent onset dyspnea. The PFT showed some restrictive changes, even though he was, not highly hypoxic. Moderate restriction severely impacted diffusion, but then he became hypoxic when he had a walking test. I mean, this guy's only 36. I checked in the records and it seemed like there was, a bunch of possibilities always with any kind of lung problems. I want to know what they've been exposed to, what's their social history. So he had a couple of things, worked in agriculture, had had some experience in the oil fields, formerly incarcerated, always brings in all these risk factors. But he denies any history of drug use or smoking. So even before I look at the images, I kind of had that to work with. Um, Remarkable, right? I mean, this person is amazing that they're not more symptomatic and the symptomatology had not come on acutely. This was sort of a gradual story. So I think this is an abnormal PA and lateral view of the chest. We can see these widespread fine micronodular opacities. They are throughout all five lobes, but I think you would agree maybe central and lung bases might be a little more affected, a little bit of apical sparing perhaps. If you look on the left, and notice, I mean, I can't really assess the cardiac contours because of the adjacent lung issues. So unfortunately, I cannot assess what the cardiac or hilar contours look like. I can see, though, that there's no effusions. I don't see any bony abnormalities in the chest. Um, on the lateral view and maybe even on the PA view, you can see that there is this extreme juxtapleural uh, kind of sparing. It looks like a fine, dark, lucent stripe. Um, we look at the coronal CT reformat, and you can see that there is widespread um, ground glass, I would say, in all five lobes that look centrolobular to me with some periseptal sparing and juxtapleural sparing or cystic um, opacities there. Fine. Could that be periseptal emphysema? Um, and then you also see more coalescent disease that is showing very high density calcification. We even look at the apices, and I think you should also be struck by, even though the apical parenchymal findings are not as impressive as the midlungs and lower lobes, look at how prominent the interlobular septa are. They are clearly thickened. What is thickening them? Well, anytime I see interlobular septal thickening, I worry about lymphatics in some sort of overdrive status. Um, and so this is where we are. Sorry, I don't know why it backed up. Nice correlation there. This is just a nice kind of 3D reformat that was provided, and you can almost see a sandstorm or a snowstorm appearance on that picture where we have all these high density, fine micronodular opacities that are largely clustered sort of in the mid lungs and lower lobes. And then one more CT picture, just confirming again that there is just widespread, pretty diffuse, high density calcific material in this micronodular morphology that has some extreme juxtapleural clearing. which again, looking back on the coronal reformat, really looks to be almost like a paraseptal cystic pattern, this fine black stripe. It also harks back to what we saw in the radiology. So this person actually, before I give you the diagnosis, of course, I want to tell you that they had to have new lungs. So this person underwent a bilateral lung transplant eventually after a workup. And this is the explant specimen of the left lung. And I will tell you that the descriptor surgically was that this was very hard, firm, heavy lungs when they were pulled out. And they were very gritty to texture when you pushed your finger down. And if you look here, especially obvious on the pleural surfaces on the right, as well as the cut section, that there is this widespread pattern of fine, whitish, gritty material, very sandy, gritty material. Now, looking under the microscope, getting a tissue specimen here, the histology specimen, we can see on this kind of medium power view that there is some high density material there. These kind of deep purple brownish lesions or collections. What is that? And then just looking at the actual lung parenchyma itself, we can see that the alveolar walls have deposition of collagen, which to me is always suggestive of some sort of chronic inflammatory process with some post-inflammatory changes, maybe the residual features of lung organizing, lung organization. And then you see a lot of dots of these little blue cells, which tell us that there is kind of a chronic inflammatory infiltrate in the tissues as well. Now, this beautiful high-powered picture that is kind of a blow-up of the upper left corner, medium power, is also showing you that these kind of purplish brownish lesions are kind of a lamellated looking collection. These are actually called microliths. They are a combination of calcium and lamellated material that is also a mixture of phosphate as well. And so these are called pulmonary alveolar microliths that are dotted throughout this lung, and that there's a lot of evidence of superimposed chronic lung inflammation. So here is the montage of all the beautiful images that were submitted with this case, which was in a 36-year-old male who had become gradually dyspneic over a period of time, had a remarkably impressive set of imaging abnormalities as we've walked through. He ultimately, because of his pulmonary function testing, as well as what was found on some pre-op biopsy, required bilateral lung transplant. And then the beautiful histology with calcium phosphate microliths, interstitial inflammation, and features of fibrosis. So this was a very rare disease. It's called pulmonary alveolar microlithiasis, and everybody needs a quick overview, right, of a rare disease. So this is something that accumulates over decades in a patient. It's an accumulation of intraalveolar, not it's not in the walls of the alveoli. It's literally accumulating within the alveolar spaces, which is explaining the issues of gradual shortness of breath because limitations of gas exchange are occurring. But then there's also chronic inflammation and fibrosis, which to me is explaining the restrictive lung defects. So these are called microliths. And interestingly, this is one of the hallmarks of this disease is something called clinico-radiologic dissociation, because greater than 50% of patients with this disease are actually presenting for another reason, and a chest X-ray is done. And so there's no pulmonary symptoms. But that's a real dissociation from the impressive radiologic findings, right? So, and the mean age of diagnosis means that this disease kind of percolates along for maybe through 2-3 decades before creating any real issues. So the mean age of diagnosis was pretty much right on the nose, like this case, in their mid-30s. Now, recently, in the past 10, 15 years, it's been confirmed that more than half of these cases are actually familial. They have to do with an autosomal recessive trait that allows this sort of setup of phosphate chelation and calcium deposition in the alveoli. There are other organs that can be involved. You can get accelerated cholelithiasis. You can get accelerated nephrolithiasis. Anybody that ultimately gets this diagnosis has to have is suggested that the family is screened for the same disease because they could be walking around with it and not know it if they're younger. So there's no real links to inhalational exposure, geography, where you live, whether you've had a prior infection or other lung injury. It's not a pneumoconiosis. But the differential diagnosis would include pneumoconiosis, depending, including, but also sarcoid histomiliary TB, calcium deposition diseases from chronic renal failure, and healed viral pneumonia. So unfortunately, there's really no treatment for this. Once you have these changes in your parenchyma, lung parenchyma, you're not going to clear it. So lung transplantation is actually the only treatment and is selected in these patients that develop chronic respiratory change. So this beautiful case of pulmonary alveolar microlithiasis is from Samar Ghanam, and I thank you very much.